Hi, I'm Dr. Jill Vecchio, radiologist and women's imager, and we're here for part number 4, going through the Patient Protection and Affordable Care Act. I got tired of the rhetoric on both sides, so I actually read the law. I've researched it, outlined it, I give talks on it, and here's the fourth part to our talk. We're going to talk about how this is going to affect doctors and you, the patients. How will my doctor be affected? First of all, do you remember the mammography screening guidelines from 2009? So those were developed by what is called a U.S. Preventive Services Task Force. This is a committee of government-appointed bureaucrats, not practicing physicians. Now, they may be insurance carriers, public health officials, other government-appointed workers that serve on these task forces. So under the Patient Protection and Affordable Care Act, PPACA, it specifically directs the president. Oh, that was interesting. Why does the president really needs to get involved in this? And the Secretary of Health and Human Services, currently Kathleen Sebelius, who's a lawyer, not a physician, to develop outcome and measurement criteria for all providers for any given program or medical condition. In other words, the President and the Secretary of Health and Human Services are going to take it upon themselves to develop guidelines for doctors and patients to use to diagnose and treat any given medical condition. Gosh, they must be really good. This U.S. Preventive Services Task Force, there can be all kinds of different ones set up. So depending on what the disease or the medical condition is, they'll set up a different task force for that. So in 2009, here's an example of what the task force came up with. Mammography screening guidelines that essentially put us 15 years backwards in screening mammography. It would have decreased the number of screening mammograms by 60 to 75%. Now, this is at the same time that we have studies coming out of Sweden and Norway, as well as the U.S., that say that screening mammography has decreased mortality from breast cancer in women by at least 30%. Wow, how did they do that? Well, part of how they did it is they ignored these studies. They chose the studies they wanted to use, they ignored other ones, they came up with their own computer models. So this is what we can expect. Now, what's the point of decreasing screening mammography? To save money. It saves a lot of money not to do screening mammograms on women between 40 and 50, to only do them every other year between 50 and 75, and then not to do them after that. So you're going to tell a 75-year-old woman, gosh, I'm sorry, we're not going to do a mammogram on you anymore. It's just not worth it. So they know it saves lives, they just decided it doesn't save enough lives. They strike again in December 2011. U.S. Preventive Services Task Force, this is a different task force, just issued new recommendations that will eliminate the need for the prostate serum antigen, or the PSA screening lab test for prostate cancer. Now, on the mammography one and on the prostate cancer task forces, there wasn't a single practicing physician that specialized in either of these areas. For the mammography screening, there wasn't a single radiologist like me. They didn't ask me to be on this task force. So there wasn't a single breast imager, breast surgeon, oncologist, nobody giving input. For the prostate cancer, there wasn't a single urologist. These task force guidelines will force me, as a physician, to violate my Hippocratic oath, to do no harm. And I won't do it. They tell me that I can only recommend screening for women over 50 and every other year until they're 75. I won't do it. I'm going to stick with the American Cancer Society guidelines of every year after the age of 40 until the patient decides that she doesn't want to have screening mammography done anymore. That's what's going to save lives. I won't violate my Hippocratic oath, and neither will thousands of other physicians. We're going to have to make a choice. Do we abide by the government guidelines, or do we do what we think is right for our patients? And that may cost us. We may not be able to participate in this system if we disobey their rules. That's in the law. Let's talk about why the American Medical Association signed on to this. Gosh, I can't imagine. They only represent 17% of physicians. Now, in their heyday in the 60s and 70s, they represented 70% of physicians. Now it's 17% of physicians. And most of those aren't practicing physicians. They are instructors in academic facilities, medical students or residents in training, or retired physicians. The AMA also has a government-granted monopoly on the publication of these code books. Earlier I talked about these CPT codes. So we have to use these little codes, these little numbers to match up a diagnosis with a lab test or treatment in order to get paid by third-party carriers and Medicare. So the AMA has a monopoly on publication of these code books. Everybody has to have them. So the AMA makes $80 to $100 million on publishing these code books, and they only bring in something like $20 million from fees and member dues and things like that. I wonder where their loyalties lie. One of the ways that we talked about when we were talking about how the law is going to control costs was through accountable care organizations. So an accountable care organization, and there are several versions of them out there that they're talking about and proposing through the healthcare law. But essentially, it's kind of what we call an HMO on steroids. It's you're grouping together the hospital, doctors, all the providers into a big lump, and they're going to get one payment, say, for a hip replacement. So for a hip replacement, you get paid X amount of dollars, and all that money is going to trickle down through everybody into the hospital, or somebody will decide who gets paid how much. That's how they're going to control costs. Then they might get bonuses if they don't spend all that money. Well, how would they maybe not spend that money? They might spend that money by not treating people quite as much as they would have if this weren't in place. Or maybe they're not going to do a couple of extra lab tests that they might really want to do to make sure they have the right diagnosis. In other words, there's going to be an incentive for providers not to give care, not to do diagnostic tests, because they're going to get paid more if they don't do it. As a patient and as a physician, I just find that warped. That is not the right way to decrease costs. In addition, this accountable care organization will focus all of the medical care on the hospitals. Well, the hospitals love that. That's why they liked PPACA. They signed on to this a long time ago, because it brings all of the patient care under their jurisdiction, so to speak. So instead of having all of these outlying outpatient centers for imaging or surgery centers or things like that that charge a whole lot less than the hospitals, now the hospitals will have control over the patients. So it's going to be the end of private practice. Already, half of the doctors in this country are not in private practice. They're employed by Kaiser or a hospital directly. So it's going to be the end of private practice, and it could be the end of these competitive outpatient facilities that can give care, excellent care, at a much lower price. Electronic health records. Bottom line, do you really want the government in charge of your health care records or your health care? But they're also going to have access to your personal medical records. So right now, doctors are supposed to set up a system that is approved by the federal government. There are all kinds of systems out there for electronic health records. And they sold this, and it does sound like a great idea. Let's have, if I'm here in Colorado, but I go traveling to Florida, and I get sick in Florida, wouldn't it be great for Florida to be able to contact Colorado anytime, day or night, access my electronic health records, and see what medications I'm on, what health problems I have, blah, blah, blah. That makes all kinds of sense, doesn't it? I think it's a great idea. The logistics of it are not quite working out that way. So, right now it's costing between $35,000 and $50,000 per physician to set up these systems. And then there's ongoing maintenance fees and payments that go for $300 to $1,500 a month. And then we have this meaningful use where you have to check off all this mountain of information every time you see a patient that's essentially just useless information. You come in with a rash, and they have to check ears, eyes, nose, and they listen to the heart and lungs and all this stuff that's totally unnecessary, but in order to get paid, in order to jump through the hoops of the federal government, doctors have to spend time doing this. It's a waste of physician time. It's time away from the patient. They would much rather be at the bedside than sitting at a computer. When the government has access to your personal medical records, let's talk about what that may mean. Are you as likely to talk to your physician about sexual dysfunction? Whether you've had an abortion? Whether you have drug or alcohol dependency? Whether you're depressed or have an anxiety disorder? I think that this alone threatens the doctor-patient relationship. Are you really going to tell your doctor everything that's going on with you like you feel comfortable doing now? Another thing that physicians are going to have to worry about is the expansion of Medicare fraud charges. So, according to this law, a person need not have actual knowledge nor specific intent to violate the health care law in order to commit health care fraud. So you don't have to know that you're doing it. You don't even have to know that there's a rule that says you can't do it. Intent is assumed. So, when Medicare passed as a law, there were 1,000 pages of rules and regulation for every 1 page of legislation in the Medicare law. The PPACA law has over 2,800 pages of legislation, and if you apply the same calculations, that would be 2.8 million pages of regulation. I put 1 million pages here because I thought it was kind of overwhelming if I put the whole amount. But probably 1 million pages of regulation, and we're supposed to know every word that's in it so that we know what to abide by. And if we can't do that or don't know how to interpret a rule or a regulation, we can be charged with fraud. There's actually not a single physician in the entire country who could not be charged with fraud. Period. Do you do everything your doctor tells you to do? I don't do what my doctor tells me to do. So, this law authorizes the Secretary of Health and Human Services, again, a lawyer, to adjust reimbursements to providers based on what they call quality measures. In other words, if you, as my patient, don't do what I tell you to do, and you don't get better, or maybe you get worse, and you come back to me, I won't get paid for that visit. If you're not better, I may not get paid. If that happens to a lot of my patients, then I might get kicked out of the system altogether. If I don't abide by their guidelines, I may not be allowed to play in their system as a physician. So, the interesting thing is that in none of these quality measures is patient compliance taken into consideration. So, they don't care that you didn't do what I told you to do or recommended that you do. All they know is that I must be a bad physician because you didn't do it. We're going to talk about tort reform when we talk about solutions for healthcare, because there is no tort reform in this law. So, the next 2 parts are going to be constitutional and judicial arguments. Very important as an American to see this part. And then the last part is going to be ideas for healthcare reform. And I hope you want to see this one too, because it is really fun. It's fun to talk about what we as Americans can really do to fix these issues. Thank you for watching. I'm Dr. Jill Vecchio.